honored to have one of the most renowned person in the field of neurosurgery, that is Professor Dr. Rasheed Jooma. Dr. Rasheed Jooma, in spite of having an excellent academic and the professional career abroad, chose to work in Pakistan, and walking on the footstep of his father, he leveled the ground for the others. Dr. Rasheed Jooma will discuss with us the neurosurgical component of the DBS in the Parkinson's disease patient. So please, sir, come on the stage for your talk.
Assalamu alaikum. It's a pleasure to be here this morning and see lots of friendly, familiar faces. And I want to start by congratulating the organizers, particularly the scientific organizers, which I guess is Dr. Malik and Dr. Nadir Ali Sayyed, because they've placed my talk between what you do before the surgery for Parkinson's disease and what you do after the surgery for Parkinson's disease. Because that's the really far more important thing and far more time consuming thing and far more impactful on the eventual outcome. So, and the surgeon's role is minimum. And so with, to that little caveat, I want to add that as I mentioned earlier before we got off for tea, I have had the opportunity when I was working in JPMC with Professor Shaukat of doing stereotactic surgery for Parkinson's disease. But at that time, we hadn't really got into implanting deep brain stimulation, although it was something that I was looking out for. And so I have no direct personal experience with DBS. I've had the opportunity to observe it in at least half a dozen centers around the world, including in Pakistan, with my colleague in Lahore. And it's something that the more I see, the more I realize that it has a great deal of promise. And I'm intrigued to see that the indications of it keep expanding if you look at the literature and listen to people at meetings. What I'm going to say to you really is largely a repetition of what Dr. Danish has already said to you, and to a certain extent prefaces what is going to be said by Dr. Bajwa after me. So this is not going to take very long. Clearly, you've all realized that the number of systems being implanted around the world is expanding, the indications are expanding, and the number of Parkinson's disease patients who are benefiting from this technology is also increasing. And the goals of the surgery are pretty obvious. We want to, at the end of the day, improve the quality in life of the afflicted individual, for whom the treatment starts out by being a harbinger of hope, but that quickly, with side effects, turns to despair. And DBS does have a role, as you've heard, in mitigating this transformation or the effects of this transformation. You've also heard that there was a very interesting trial, which was the first randomized trial, and quite honestly, neurosurgeons are extremely wary about randomized trials. We ourselves are extremely convinced about the veracity and efficacy of our work, but we've had the bad experience of having one or two of our procedures subjected to a randomized trial and they've died a natural death immediately. So the mortality of our things when subjected to a randomized trial is quite high. So the neurosurgeons were actually quite concerned about this trial, but in fact it showed that in the short term anyway, it does have a benefit, and the patients who were randomized to surgical treatment in this trial did better, as you have seen in a slide before. So, oops, I'm sorry. So, the important question which was addressed earlier and continues to be an important question for every practicing neurologist is, at what stage am I going to consider my patient? There's no doubt that you would, it would be unthinkable to say that I've never treated this patient and I'm going to go for DBS. But interestingly, I must mention that there was a report from Italy a few years ago of a patient who had taken non-DOPA medications, and about 7 or 8 years into his disease was told, you now need to go to L-DOPA, and he said, I don't want this drug. I know enough about it. I know about its side effects. I know about its downsides. I don't want it. I want DBS. So there's at least one person reported in the world literature who went directly to DBS, and at last count his outcome was favorable, as you would have expected. But obviously you'd have to go down that road, and the important thing that was presented to you earlier was that is also in a sense a diagnostic test of how well the patient is going to do. Because if you do not respond to L-DOPA at all, then you're not going to respond to DBS. And I picked this slide up because I think it very nicely illustrates the whole business of early versus late. So if I can just spend a minute speaking to this slide. The first bar is somebody who just has medical treatment and they're diagnosed. As soon as you start even a small dose, they do very well, and that's the honeymoon period. And then there is this long road of motor fluctuations, dyskinesia, the kind of problems that all people with Cinemet have. And then you get the super added problems, and this is the progression of the disease. So the two small cylinders at the end are the treatment-resistant axial symptoms, the freezing, the postural instability, and the cognitive decline. So that is there in the background. However, what DBS does is that it gives you, it adds to the initial drug honeymoon a second honeymoon period. So you have a second beginning, and then if you do this earlier, you'll still have problems. 7, 8, 10 years, 15 years is the long period that we heard about. You'll still have those problems as the disease progresses. But the troubles that you have with motor difficulties will be considerably abbreviated. So I thought this, and I don't know, sitting down, if you can see the time bar at the bottom. The time bar at the bottom is onset to 20 years. So I thought this was a very useful slide because it very nicely illustrates what the natural history, what medication is, and what DBS does. So there was this trial that was reported a few years ago, and this trial has been widely circulated and noticed. It's the early STIM trial. It's called the early STIM trial. The formal name is up there. And in this, the earlier trial that I mentioned to you was people with advanced Parkinson's who'd been Parkinsonian for many years. To get into this trial, you had to be Parkinsonian for no more than, I think it was 7 or 9 years. And the motor complication history should not have been for more than 3 years. If you did that, then you got into the trial and you were separated into best medical therapy and DBS. And again, the DBS patients did better, particularly on last follow-up. And this trial had quite a lot of impact because it changed the FDA's labeling of the DBS device from for advanced Parkinson's disease to for Parkinson's disease. So this was a huge step forward for surgical treatment of the disease. So the common targets were addressed very nicely, and I'd like to congratulate Dr. Shabbar. He seems to have disappeared, but I'd like to congratulate him for his talk, because it really, you got a sense of the wealth of experience he has, and with all targets. The one target he didn't speak to, but a lot of neurosurgeons or people who are in the field are looking at, and that is the PPN, because the PPN is even smaller target than STN. It's further down, so you're really now getting into the medulla almost, because it's in the pons, but it seems to be, and it's still experimental. It's not a general purpose target, it's still experimental, but it seems to be the place where if you put your stimulating electrode, you can get improvement in some of the freezing and gait issues that the patients have. So I'll skip over this, because to me this is an important slide, but we have heard this and we're pressed for time today. But the results are out there and we know what they do. Just one thing, and that is that it's not so much the duration of the disease that's important as much as the age of the patient. They're both important factors, but between the two, it's not the duration that's important, but it's the age. And generally people of 70 and 75 don't do very well. And one of the big things in DBS surgeries, which you may have appreciated, is the psychiatric, psychological side effects and complications. And they're much more severe if you're an elderly person. So I just want to quickly say that it does have complications, and all of these complications, which are surgery related and hardware related, and then the neurostimulation related, are all things that get, the incidence is lowered with experience. And so in centers that do a lot of this, these are really things that you see infrequently. However, there are some things that are unpredictable, and one is that the hemorrhage is unpredictable. Surgeons have done a lot of work to try and reduce that risk, and usually like to quote a figure of 2%. And similarly, the mortality is low, but it's largely in elderly patients, and the most common cause is usually a pneumonia. There was a sense of, we've been doing this for so long, where are we 10 years later? Well, 10 years later, we can look back and say that if you have advanced Parkinson's disease at the time that you have the implantation, then your quality of life will improve, although that period may not be very long. However, if you have it done early, before you're seriously crippled with this thing, then you have a better period of clinical benefit. So the message that comes out from the looking back at your experience is that the patients that you did earlier in the course of their disease or earlier in age are the patients that do better. There's been quite a lot of work on cost effectiveness, and you've heard one talk from a colleague in North America. You're going to hear another talk from a colleague in North America, and I bet you even the second colleague is not going to say a word about cost, because that cost is something that they don't even think about. If the guy walks into your office and gets in past the secretary who's checked his insurance papers, you don't have to worry about that. Here, when you sit down with the patient, the first thing that you have to discuss is कि जिसका खर्चा कितना होगा और वो कैसा होगा. And quite frankly, at least my patients, they say, डॉक्टर साहब आप कितना देंगे? They don't say कि इसमें इस पूरे खर्चे में आप कितना मदद करेंगे, आप कितना करवाएंगे. So this is very important, and so it's important for us to look at this and say, is this a technology that is a luxury for Western patients? Or is this a technology that is expensive, but you can make an economic case for? And as I said, and if you look at the literature, and most of the literature is Western literature, the last paper I saw was a very good paper from UK on this. But if you compare the initial capital cost and then the maintenance cost against the medical and medication costs of medically treated Parkinson's disease who are appropriate candidates, then the cost effectiveness does come out. And this has been seen on a number of patients over time. So coming back to the thing, even the cost benefit is clearly in terms of the younger patient and not the older patient. And so I think as Pakistan builds its experience in Parkinson's disease surgical treatment, the bias will be towards the younger patient, whereas in Western practices, a lot of the patients are at an advanced stage. And the other thing that people have looked at is, so why are people reluctant to have this surgery done? And economic burden is obviously an important thing, but fear of complications. And so I guess that's where having a good team, a good center, having good experience, and having good communication with the patient really matters. And I put this slide up to reiterate what I started off by saying, which is that the neurology comes in the beginning, the neurology comes in the end, and the neurosurgeon is kind of stuck in the middle, and in this particular side, off to the side. So it's really important, in my view, to do this in collaboration with your movement disorder neurologist, who is the lead person in the whole business. Finally, a couple of operative slides which I picked up from a friend's article. In the first frame, you put local anesthetic, apply the frame, you put the localizer, the MR localizer on the frame, you move the patient to the MR with the head holder placed, put him in the coil, do the MRI, and then while the patients move to OR, you do all the planning. You use the C-arm, which is the image intensifier, to look orthogonally through the frame, because in the center of the frame, and I'll just show that to you in a minute, are crosshairs which help tell you where your electrode is. So when you actually dial in the numbers on your frame, which you've derived from the MRI analysis by your software, you get a particular target, and this is now you're looking through the frame on the C-arm, and first the cannula comes in, and then the electrode comes in, and that central ring, when you get to the center of the central ring, you know you're in the target, and that's when you then move to the microelectrode recordings. And the STN has a very characteristic signature. It's very loud, it's very active, and usually finding it is not too difficult if you're in the right region. I just want to now move away towards what's happening, what's new and exciting in this area. So what we do with trying to find the target is we use neuroimaging. We started off by doing ventriculograms, then we did CT scans, now we do MRI and CT scans fused, and you can change the order. You can do your MRI stereotactic and your CT and you bring in, or you can do your CT stereotactic and bring the MR in, which you've done previously. But this is from a 7 Tesla magnet. And in the 7 Tesla magnet, you can clearly see the round red nucleus, and you can clearly see the subthalamic nucleus in front and off to the lateral side. And so now there is the real possibility of directly targeting this, making this thing simpler and better. Indeed, some people are now using intraoperative, and my slide's not in order, intraoperative. So you place a localizing device on the head, you scan the patient inside the OR, you get the information that you want, and you target right there and then. The other thing, and that helps you, is, and I'm sure my neurosurgical colleague, Dr. Nasir Razawan from Lahore, will be very interested in this. There's a lot of interest in Dti Tractography. So you do diffusion tensor imaging, you get information about the tracts in the brain on the MRI, and that's what this slide is, and the color of the various tracts, and you use that to actually localize, as you'll see. So on the first panel there is the dentate red nucleus thalamus cortical tract, and STN is in that pathway. And what you can do is then you can segment that, you filter that out. So you first get all the fibers, the red fibers crossing, green fibers front to back, blue fibers vertical, and you filter that all out, and you can use DTI to actually localize the STN by virtue of its connections, which is really exciting, I think. So, and all this you do because you, I understood what Nasir was saying, and Nasir understood what I was saying, but the trouble is that you've got an electrode in your hand, you now need to place it in the thing, but you can't see it except through all this. And so you put this between yourself and the patient, and you get into that small area. And this is the slide that was out of order. This you can use inside the MR in your surgery, and this gives you great versatility, great this thing. And Nasir, what's good about intraoperative is that you do the image after you open the dura and the CS is released. So you're imaging the brain in the displaced state. And so that little sub-millimeter inaccuracy that comes in is also eliminated. So this brings me to just quickly. I was talking to the next speaker, Dr. Jawad, who was telling me about advances in the electrodes. So there's a lot of advances in how you image, how you target, and in the electrodes. And so that's why I put this slide in, just to show that the various companies are vying with each other for this business by innovating in electrodes. And that brings me to my last slide, which is that it's established, it's safe, it's got benefit, and the trend is to consider earlier. And the important thing now is that the technical advances in the imaging, in the localization, the electrodes, and in the pulse generator, where you have longer and longer batteries, is making this surgery much more effective, efficacious, and helpful for the Parkinson's patient. Thank you for your attention, gentlemen.